I want to ask how many people in this room came to the Baptist within the last 5 years? Just raise your hand. Way up, I want to see. 1, 2, 3, 4, 5. Maybe half of the room. Okay. So if you'll indulge me a little bit, I want to give you a little history because I feel that it's an important opportunity at any time to give you some history. This is a photograph of the entrance to the main hospital, turn of the century. I actually have never seen this photograph, and if you notice the ivy going up the walls, and there's air on either side of the building. I think it's a fantastic photograph. And it reminded me that I've been here for a long time, and I feel a responsibility to share some history with you here. And certainly after yesterday's lecture with Dr. Porter of where medicine is and where it's going, I'm trying to put things in a little context in the big picture viewpoint. I had a patient recently, and I was taking history, and I said, have you ever been admitted to the Baptist? And the patient said, no, but I was discharged. And I said, what do you mean? He said, well, I was born at the Baptist in 1932. So that took me back when the Baptist was a total hospital. My father had his prostate taken out 20 years ago at the Baptist. He's still alive. My mother had her total knee at the Baptist. She's passed away, but I affectionately am committed to the Baptist. So where are we now? We've come from a general hospital to a musculoskeletal hospital. And for all of you that are in support, which we all are here, this is a good thing. And this slide shows you that we're in a growth industry. I tried to pick things to talk about that are current. There will be some pearls. There will be some good information for the nurse practitioners. I don't want to make it too formal, so we have plenty of time. If you do have a question, you don't have to wait till the end. You can interrupt me at any time. This study just came out this summer in Arthritis and Rheumatology. That's our professional journal. It used to be Arthritis and Rheumatism. They changed the title to Arthritis and Rheumatology. But this is a kind of a seminal study, and primarily the information comes from New York and California. But they looked at almost 3 million arthroplasty patients to see where they came from and what is the trend in arthroplasty. So of these, this whole time period, you can see 97% were from non-inflammatory arthritis or osteoarthritis and 2.7% from inflammatory arthritis. Now, you don't have to be brilliant to know the demographics of our population and us as the baby boomers are getting older. So clearly a growth industry. I want to show you what's happened with the advent of some of the medications we've used in rheumatology. So the initials here, NIA is non-inflammatory arthritis, IA is inflammatory arthritis, and then subsets of rheumatoid arthritis, juvenile idiopathic arthritis, and the spondyloarthropathies, which would include psoriatic arthritis and ankylosing spondylitis and arthritis of inflammatory disease. But just look at the numbers. From 91 to 2005, inflammatory arthritis, these are arthroplasties, knees, shoulders, and hips, has more than doubled. Fantastic volume, all right? In inflammatory arthritis, basically the same, 5.1 to 5.1. So it kind of tells you that whatever we're doing with inflammatory arthritis, it's not growing to the destructive change that it was. When I trained in that building over there, the Robert Brigham, we admitted people for 6 weeks of bed rest, and they had deformities. And for the whole 70s and 80s and 90s, there wasn't a whole lot we could do to reverse things or halt the progression of the disease. So that's a key point. These are stable. RA, maybe a little bit of surgery going down. The age of their surgery may be going up. In juvenile disease, quite a dramatic drop in the amount of surgery that these children, as they become adults, need, primarily due to medications that we've introduced. And in spondyloarthropathies, a little increase as these people live longer and get older. And one of the premises under this is that in these inflammatory diseases, as we get better and we've treated the population or stopped some of their disease, they're actually having surgery for osteoarthritic disease, non-inflammatory disease, but they're still having surgery, and they still are labeled as a rheumatoid or whatever it might be. This just graphically shows you that the increase is huge with non-inflammatory disease and relatively stable in inflammatory disease. Now just do a little math here. If the rate per 100,000 people is 124 arthroplasties, so 10 times that would be 1,240 in a million patients, right? And if we have 300 million people in the United States, the math is pretty rough, but we're doing roughly 500,000 arthroplasties. I'll show you the next slide. If we do knees, hips, and shoulders, if you do the multiplication on this, there's about 500,000 knees and 750,000 hips that we're doing a year. And if you look at the infection rate on those as 1% acceptable standard, and you then figure each infection costs $100,000, you do the math, it's probably $8 billion a year on infections that it's costing this country with the volume of arthroplasties that are being done. Just something to put in perspective. So our work in our perioperative care, if we can cut down on the increase of infections or complications, the exponential reward over time is huge when you consider the volume that's being done here. So another interesting thing, which I don't think I was aware of, is that the growth here seems to be in knees and shoulders. Look at the hip rate. It's kind of doubled. There's no question it's increased. But knees, more than that, shoulders more than that. Now the volume of shoulders is relatively low, but the volume in knees is huge. And these are a little more difficult in terms of post-op recovery and complications. So to focus on knees and complications around knees is very important, exceedingly important. And then, again, just to show you down in the inflammatory arthritis, relatively stable in terms of how much volume is being done with these. So the Baptist is positioned in a great place in terms of growth, the focus factory concept, and for us to get it right.
Sir, do you think that the growth in knees, as opposed to hips, is related to the obesity epidemic?
I think it's related to, the interpretation is related to obesity and activity. As the population becomes more active and lives longer, and the lifespan is going longer. So we're operating on people now that, 20, 30 years ago we didn't do. And so proportionally, the proportion of inflammatory arthritis that's having surgery is markedly going down. It's almost halved, even though the volume of surgery is going up tremendously. So what I'm going to talk about later in the talk will be the nuances around inflammatory arthritis, which are very important, but the volume, for our viewpoint, is really in non-inflammatory arthritis. This was another study more recently, and I want to highlight, what I showed you was 91 to 2005. Now the biologic drugs and the active drugs we use in disease now really came in 99. We've had like 14, 15 years of experience. So here's a more recent study in Spain. And Spain is, I guess, has 19 different states or something, and they sampled it appropriately. But they demonstrated that in rheumatoid surgery for major arthroplasty, they have decreased the rate of from 25% to 7.4%. So a big drop around the world. It's happening everywhere. They don't use the biologics. The economies are different, so we have a little more use of them here, but these drugs are pervasive around the world. So that's just a little bit to show you where we're positioned, which is a very good place. Now I'm going to talk about the importance of physical and history and some pearls. And this is what? What is this?
Avatar.
This is an avatar, okay. And how do you know it's an avatar? Well, it's got blue skin, pointy ears, and all that. You don't have to be a doctor to recognize that that's an avatar. But what I would like you to do is be observant when you see these patients in pre-screening, and sometimes it's the tiny details that make the big difference. Now, we're going to go through a lot of this. Complete history and physical, and that means take the clothes off, and you'll see why shortly. Skin we're going to spend some time on. Neck is important in rheumatoids because frequently or commonly cervical spine disease may go undetected. Now, I think with the fibro-optic intubations that occur these days, it's probably less of a problem than it was years before. But when I was trained, we always had to get plain films of the cervical spine to check for subluxation before people would go undergo anesthesia. I think anesthesia has advanced a lot, but keep in mind, necks can be asymptomatic but still be significant in terms of disease. Heart disease, key point, rheumatoids have a 60% higher increase to cardiovascular disease. Huge. So if you see RA, think heart. I will say same thing for psoriatics, same thing for spondylitis. I've had 2 patients in the last year that were in their 50s that had ankylosing spondylitis and or psoriatic arthritis that died of sudden death from cardiovascular disease that was undetected. So I'm very aggressive in looking at lipid profiles and family history and all that in any of these people with inflammatory disease. Heart disease is an inflammatory disease, so keep that in mind.
So the disease is coronary, right?
It's coronary, yeah. Yeah, but it's an accentuation of, no, it's coronary. GI, the usual suspects here. So when we see somebody ahead of time, if they've ever had symptomatic gallstones or gallbladder disease, I recommend a pre-arthroplasty cholecystectomy. That may sound dramatic, but when you're faced with somebody who post-op on their 4th day has acute cholecystitis and gets septic, not a very good thing. And I'll stop right here and say, the premise of this lecture, if you don't take anything else away, is most of our surgery is elective surgery. That means the best time for the patient, physically, best time for the patient mentally, and the best time for the surgeon. It's not a good idea for the surgeon going to a big party Thursday night and going on vacation Saturday and operating on a huge 12-hour case on Friday morning. So that's very important to keep in mind. It's elective surgery, and I am never afraid to cancel a case when I feel what I could do pre-op could change the outcome. If you heard Dr. Porter yesterday, he gave an analogy of a headache clinic in Germany. They had mixed care, then they had focused care. And when they looked at the cost, the focused care cost more in the beginning. There was upfront cost because they were doing a better job of evaluating them. I feel, and I want to feel and continue to feel, that in our pre-op evaluation, it may cost more to get a pre-op evaluation at the Baptist, but the energy put into that will ensure a better outcome over the course of their care cycle. Now, how do you convince the insurers of that? That's our challenge, but I think that's a true fact in terms of the care that we give. Diverticulitis, Dr. Surgeon called me the other day, said this patient had diverticulitis 3 weeks ago. He's doing fine. Can I clear him for surgery? I said, I don't know the patient. I don't know his comorbidities. I don't know anything about him. Well, how long does it take after diverticulitis before you can get cleared for surgery? Well, it's not a cookbook answer. It is, was this his first attack of diverticulitis, second attack of diverticulitis? Is he a diabetic? Is he on steroids? I don't know the answer. I advised canceling the surgery and having a careful evaluation. One of the other doctors came up and said, well, we're told after 4 weeks after diverticulitis you can operate. Well, it's not that simple. You have to look at the entire patient. So you've got to realize there's a little art to this. It's not all, there's not evidence-based medicine on every patient that comes through pre-screen. GU situation. We frequently get calls with people with bacteriuria or a urinary tract infection. Well, what is the history? Is this one they have every month? Have they had 5 children, all vaginal deliveries, with a relaxed pelvic floor and increased residual? So you've got to take a history, and you also got to look at the anatomy. Many times we'll see people, and they've never been evaluated. Do they have a double collecting system? Do they have a stone? Do they have an obstruction? So history is important, and don't be afraid to delve into it. And if it's not clear, and you're uncertain, you can postpone surgery. It's not the end of the world. It's elective surgery, best time for the patient, best time for the surgeon. Medications, we're going to go in deeper too, but just the one thing I found very commonly, yes, all the oral medicines are taken, but the patient forgot to tell you, oh yes, I'm on Remicade, I get it every 8 weeks. It just doesn't make it on the chart. Or I'm on Prolia for my osteoporosis. Just doesn't make it onto the chart. So when you talk medications, talk about pills, but also talk about injections that may be important. Immunizations, just because our patients come through in this population, you cannot give a shingles shot to anybody on biologic therapy. It's contraindicated because it's a live vaccine. But if you have the opportunity, as you do, make sure they get their flu shots, make sure they get their pneumococcal vaccine, and encourage them to get zoster if there's a window before surgery, if they're seen far ahead of time. I would love to see a protocol in our surgeon's office. Many are booked 6 months ahead of time. We could do a lot of these things on a lot of these patients if we only thought about it or had some kind of tool that would remind us to check it off. Now, I mentioned looking at details. This was a patient I saw last week. Artful nails, beautiful, okay? I pay attention to nails. This is not a French manicure, okay? I thought it was when I looked at it, but this is onychomycosis of a lady's nail. She also happens to be on Humira as her biologic. She also happens to have rheumatoid arthritis. So when you examine these patients, look at them carefully for a tip. Maybe she's at risk for underlying fungal infection when she has her surgery. Maybe she's on steroids as well. So look at them very carefully, and you do have to disrobe them to look at them. This patient came to me ostensibly supposed to have a total knee. This is a typical post-phlebitic leg with increased pigment change. You can see the scars from prior ulcerations and breakdown. Not a good patient to put a total knee in. The outcome is only as good as the milieu that it goes into. Now, the surgeons love to operate, and sometimes they get away with it. But I tend to be cautious, and I would recommend that probably this patient not have a total knee. And we've had countless examples where this has happened, and then we're on the other end of treating the infected knee after the resection, and then they get the infusion. Then they get the fusion of their joint. Back on the GI thing, one thing I should mention is people with cirrhosis do very poorly with this, with implants. So I'm very, very reluctant to clear anybody with cirrhosis for an implant. I mean, 50% of them will get septic. Sometimes wounds seem trivial, and sometimes they occur from when they went through pre-screening and when they enter the bond center. So the nurses in the bond center are another filter that people have to go through. So if you got knocked against your wheelchair like this patient did and cut open your leg, and you've got some erythema around there and you're going to get a joint above it, I would cancel surgery and fix the wound, make it heal. You don't want to rush to surgery on this kind of thing. So you've got to look at everything. Another condition which should be taken care of ahead of time, and I get referrals from our surgeons who are aware of that, and that's psoriasis. You don't want to operate through a psoriatic skin, and you don't want to operate on somebody who has extensive disease. This can be fixed fairly quickly. So if it's a delay of a couple months, we can deal with this medically. Here's a worse example, and you don't have to, you can understand why if this were up here, you don't want to operate through psoriatic skin. That's going to put you at risk for infection. I mean, psoriatic skin is exfoliating, it's got fissures in it, it's a great portal for infection. There's a phenomenon that occurs after surgery also in psoriatics called Koebner's phenomenon, which is a flare or appearance of psoriasis in a wound where trauma has occurred. I personally haven't seen it, but it's something to watch for if you have a patient who has psoriasis has an incision, and then they have a flare of psoriatic appearing skin around their wound. This lady had it on both sides. So patients like this with an extensive disease, biologics will be very effective. And they work very quickly. So we could probably clean this up within 12 weeks or so. This is a patient of mine. This is how she presented. She happens to have lupus, and she's on steroids. She needs surgery. I think you can see that this did not work. She also has bilateral total knees. So surgery is the only option. We can't not do something. And I had to see her for preoperative clearance. This is what the leg looked like before surgery. And you can see her hip scar and her knee scar, and she's got them on the other side. But what she also had was a wound vac in her back from her laminectomy wound, which dehisced, which she had previously to the fall that caused the fracture in her leg. So we've been dealing with this for months, and I'm in the position of clearing her for surgery, which is major surgery from the hip to the knee, with this in her back. And we had to do it. We covered her. We cultured her, the base of this, and we did well. And this is her post-op. I just saw her this week. And this is her back wound, which is almost healed in. Wound vac's gone. Now, between her surgery and these slides, she developed cellulitis of her right hip, which resolved with a 1-month course of oral antibiotics. She's now on suppressive antibiotics, treating her much like erysipelas. No deep infection, but skin infection, and worry about recurrent skin infection. So this is a milieu you don't want to put a total joint into, but we have no choice, and we're doing the best thing we can under the circumstances. So patients like this, she may be on antibiotics for indefinitely. So laboratory testing can be helpful on these patients, and a few specific things about the rheumatoid patients. CBC and DIF, a lot of these patients are anemic, so you want to look at that. BMP, check their electrolytes. One thing you might not do routinely is check a uric acid. Now we know that I think 2/3 of our patients have BMIs over 30, 35. Metabolic syndrome is common, and I'm going to show you some information that would make you think why you should order a uric acid. The obvious thing was you don't want a post-op gout flare on day 3 or day 4, and the hip's doing fine, but they can't walk and they're stuck in the hospital because they have podagra of both feet. So that's one reason to check the uric acid, but there are other reasons as well. We'll talk about it. Vitamin D levels are important. I check them on all my patients. It's important. Vitamin D is not only important for your bones, but for balance. And people who are recovering from joints need balance. So this is something you want to check 6 months ahead of time and replace. 40% of our patients are vitamin D deficient. I'm vitamin D deficient. I go out in the sun, I garden, do anything, I'm vitamin D deficient. So I take vitamin D for the rest of my life. And anticardiolipin antibodies, antiphospholipid antibodies, common in the lupus patients. We don't see a whole lot of lupus here, but the screening that Rich does, I don't know where Rich was here, is very important and something to think about, especially in the lupus patients. This is an example of a patient that Fred knows well that had horrendous, she passed away, horrendous Tophaceous Gout, refractory to all kinds of therapy. So there's nothing worse than having something like this with a gouty tophus eroding through your skin post-op and creating an infection when you've had a total joint put in. Not a good thing. So this is new information. You can see August 27, 2014, a study from UK, and they looked at patients with gout, and they found that the risk of women having a cardiovascular event over 50 years of age was 25% higher than it what you might expect, and that's a heart attack, congestive failure, or death. Men's raised a little bit, but the women also had increased risk for angina, TIA, and stroke. Now, those of us who deal with a lot of gout, and there's evidence to show that uric acid really aggravates hypertension. It's a risk factor. Hyperuricemia is a risk factor for stroke and heart attack. But gout is only those patients who have clinical disease and hyperuricemia. We currently don't treat asymptomatic hyperuricemia. We treat gout. So for every gout patient, there's 4 patients walking around with hyperuricemia. And if that's the case, these people are at risk for cardiac disease. So I would make an argument, especially in women now, that we should be checking uric acid in women as part of our screening in those folks with metabolic syndrome at least. So anybody with diabetes, high cholesterol, hypertension, obesity, check a uric acid. It's not part of the panel. It used to be. It was taken out. We'd like to get it back in, but it's not there now. And that's a typical post-op gouty toe. And I'll just give you my way of treating with this because we see it very frequently here. There's all kinds of regimens. I use Celebrex here because it doesn't interfere with platelets. And a lot of our arthroscopic surgery surgeons will give Celebrex pre-op for pain control. And it can be taken up to the time of surgery. So post-op, there's anticoagulation, everything going on. If you can use oral medicines, 2 Celebrex at the onset, 1 twice a day with food. Colchris, which is now colchicine. Colchicine used to be 6 cents a pill. Colchris is $4.50 a pill. That's because the FDA took colchicine off the market. A drug company bought it, did a study for 12 weeks, got a new patent, and now it's $4.50 a pill, to the angst of all rheumatologists. But we have Colchris. 2 at the onset, then 1 twice a day, not like when I was trained, 2 at the onset, 1 every hour till you got 8, or diarrhea or pain relief. Nobody does that anymore. It's twice a day. And this is a little trick I learned from Paul Fremont Smith. Cortisone, which is synthetic ACTH, has an independent anti-inflammatory effect. It also stimulates your own adrenal corticosteroids. But if you give a dose once and repeat in 12 hours, it really works dramatically. And I've used this in the outpatient area when they have to go home. It's a nice little trick. Works well. So think about that if you need a cookbook to treat gout.
About indomethacin?
What's that?
Indomethacin.
Oh, yeah, Indocine's great. About 40% of people get CNS side effects from it. I use it. It works. One of its metabolic byproducts is close to LSD. So you've got the GI effect, you've got the renal effect, and you've got the CNS effect. Good drug if they can tolerate it. And I generally give the 75 SR twice a day and then taper down after that. So let's touch base a little bit with the medications that are a little more specific to the rheumatic diseases, and I'll tell you how I deal with them and my thoughts on them. We have categories. The NSAIDs you pretty much know, and the steroids. We'll talk about methotrexate, and then we've got these kind of old age drugs. These are from the 70s and 80s and 90s, actually all of these. This one's primarily for lupus, and then the biologics, which we'll kind of get into a subset for. So NSAIDs first. I think the standard here, we stop at least 7 to 10 days ahead of time just because it's easy. But if you want to get scientific about it, you should stop 2 or 3 half-lives pre-op. Now, the half-life of ibuprofen is 2.5 hours, so theoretically, you could stop a day ahead, and that would work, but we do a week. Naproxen, longer half-life, got to stop longer. And you can go through any of the 30 non-steroidals, figure out their half-life, and decide when to stop. But if you stop at a week, you're probably in pretty good shape. Celebrex is the only one you can take up to that time. Aspirin, obviously a week, and the COX-2 drug, the Celebrex, which we take up to time. So fairly cut and dried on the non-steroidal agents.
Jerry?
Yeah.
We see a lot of post-op patients who have to take anticoagulants.
Mm-hmm.
Are CARTs2 safe with an anticoagulant like Coumadin or new oral anticoagulants because it has no platelet effect?
I mean, I use them. Theoretically, they're supposed to be, but we've seen GI bleeding from Celebrex. There's no question. So if it's a high-risk patient, you know, I'm going to back off on everything. But if it's a healthy patient, stable, everybody is at risk over 65, and when they're on your drugs, they're at risk. I mean, it's not
It's not a contraindication.
it's not a contraindication, right? Precaution. Many of our patients will be on stable steroid doses. What do you do? Again, this is what I do. It's easy. It works. And a lot of people post-op have nausea, vomiting. They're not handling things well. Hydrocortisone, 100 milligrams IV with pre-op meds, IV intra-op, and then Depo-Midrol 40 to 80 in the recovery room, which lasts a couple days. So you're covered. So they can take their steroids up to surgery, morning of surgery, small glass of water. You do this around surgery, they're good for a couple days, then you can resume their steroids. I've seen anesthesia write awfully complicated tapering things. You don't have to get that worked up about it. This works. Now, methotrexate, some things you need to be aware of. First of all, it doesn't work well with Bactrim, so don't use methotrexate and Bactrim. You'll get toxic. Stay away from methotrexate and Bactrim. I found, again, this is July 2014, World Journal of Orthopedics, a review article. 5 retrospective studies showed no difference in infection complications or wound complications when methotrexate is not stopped. So we do not stop methotrexate. Early on, we've been using methotrexate since 1978 here. And you can just accept that. You don't have to stop methotrexate. And one trial showed that when you do stop, then more people have flare of arthritis, which worsens their ability to be mobilized after surgery. So another reason not to stop the methotrexate. Consensus, continue methotrexate. These drugs all have the propensity to cause neutropenia, and so the general consensus is hold them for a couple days pre-op, and then when things are stable, you can resume post-op. We don't use these a whole lot, although in the inflammatory bowel disease, sulfasalazine is around. This is Areva, leflutamide, which is an oral drug. It hangs around forever. And there's no consensus, but one of my colleagues, an orthopedic surgeon, called me one day when I said, don't stop it. And he said, well, I found an orthopedic website that says I must stop it. And in fact, there is an orthopedic website that says you must stop it. So there's no consensus. It doesn't make sense to me why you would stop it. 2 weeks would make a difference, but since I found that website, I stop it. There's no evidence-based medicine confirming one way or the other on Areva. Hydroxychloroquine, which is Plaquenil, has been around since the 40s. It's an anti-malarial drug, and this really doesn't cause any problems and can be continued perioperatively.
So that's stopping before. How about when do you restart them, like the Areva and the Imuran?
With drugs that we feel could impair wound healing, my recommendation is when the skin of the operated incision is healed, resume your drug. Okay? Now, if you need the cyclosporin or cyclophosphamide, you know, for another reason, you might have to move it up. But I want that skin to look like the skin on the other side. Now, the biologic agents, I don't want to confuse you. To let you know there's a little rationale behind this. So infliximab is Remicade. You see the X? That means it's a chimeric. It's got mouse and human. There's a method to the naming of these things. Adalimumab, UM, means it's human. So there's another thing to tell you which ones are human as opposed to developing antibodies. MAB is monoclonal antibody. So these are 5 of the anti-TNF drugs, but look at the variation. Enbrel, 1 week. Remicade 4 to 8 weeks. So when are you going to stop? You got to know what drug they're taking and what its interval of therapy is. And we'll look at the other ones. These are some other drugs that we have. Again, given monthly. Rituxan is every 4 months, 6 months, whatever. And some of these are newer drugs. This is Xeljanz, and this one just came out this year for psoriatic arthritis called apremilast. So the American College of Rheumatology gives position papers to us on it, and this is their position paper on biologics. They should not be used during the perioperative period for at least 1 week prior and 1 week after. Consensus. Now, if you go to the companies, and I've done this, some will have an answer, some will not have an answer. Bristol-Myers Squibb, which is abatacept, Orencia, said based on the half-life, suggest withhold 2 months prior to surgery. So you are left hanging between a professional society and a pharmaceutical company, and try to make it simple. I would reduce it to withhold for 2 dosing intervals, whatever that interval may be. So if it's Enbrel, it's 2 weeks. If it's Remicade, it's 8 to 12 weeks. And there's no definitive study. Most of the studies are retrospective to alleviate us and our concerns one way or the other. So that's what I boiled it down to.
The concerns here are for infection, not for wound healing.
For infection, yes. Yes, Edie.
The concern is that when they go through this perioperative cycle and we stop most of these medications, they can flare up their arthritis. Would you advise that going from a long-acting biologic to a short-acting for a period of time, peri-op, and then...
That's a nice, it's a thought, but realistically, what you have to go through to get them approved to take their drug and go through everything, it's not a realistic option. It's really not. It's an interesting thought. Usually we have a month to plan these things. I mean, I've seen 6 patients that we saw for infection. You took the history. The rheumatologist didn't talk to the surgeon. They got their Remicade 2 days before they came in for the hip, and they got an infection. Now, that's anecdotal evidence, but it's enough to skew me to want to go this way. So you can't realistically change because they're on a program and pre-auths and certifications. It just doesn't work. This is a slide from Clinical Infectious Disease 2013. It's an approach to a workup of a suspected infected joint. I will tell you, if you read the book that Rod Turner wrote, we have this chart there 20 years previously. It hasn't changed a whole lot in 20 years. And I'm just going to go through it quickly so you have a sense of how we approach this. This lady came to my office for a second opinion. And this is what her hip looked like. That's her hip. Now, if you see enough of these, you know this is an infected hip. It looks like a bubble, and it is a bubble, but it communicates with the hip. Her doctor was trying to treat this by episodic aspirations. It is not going to work, okay? It is not going to work. You see this once, this is an infected hip. You don't have to guess, is it superficial or deep? This is granulation tissue. They will drain, they will heal, they will drain, they will heal. She grew enterococcus and she had a resection. So if there's a sinus tract or persistent drainage, of which only 25% of hips have, they don't have symptoms, they don't have fever, they don't have redness, they have pain on weight bearing, and maybe a high SED rate or CRP. So this is easy. Sudden onset, especially if they went to the dentist 2 weeks before and whatever, that's easy. This is the one that's a problem. So here, they've already seen the orthopod most of the time. History and physical, as you and I have all reviewed. Plain films, which may show a lucent line. I would add in here, if they've had their surgery over a year ago, a bone scan may be helpful. Again, this isn't somebody who just has pain on weight bearing and you're trying to do a workup, because the bone scan may be hot. It can be hot for a year after surgery.
So, wait, is the bone scan going to tell you about the surgery or osteomyelitis or what?
It'll tell you if there's increased uptake on the delayed views, it will be indicative of infection. Could be loosening too, but infection, in the setting of, sed-rate and CRP and all that, it would lean you
Plain
to
looks reassuring.
if it's negative, it's reassuring. And many times we will order them in our patients just for that reason, to be negative. Blood cultures, I would argue with, they're very seldom positive in these patients unless they're septic. So if there's no infection, you're done. If you suspect infection, go right to arthrocentesis. Cell count differential aerobic and aerobic cultures. And the significant cell count is coming down and down and down and down and down. When I trained, cell count of 50,000 was diagnostic of infection. Now we're down to 2,500, 1,500. It's an art, it's a judgment call, but there's no absolute assurance because we've had infected patients with relatively low white counts. And also, Brian, who just joined us, Dr. Hollenbach, if you don't all know him, but we kind of would like to do a study doing arthrocenteses on joints at 1 week, 2 week, 3 week, 4 week after surgery to find out what normal white counts are in joints after surgery. So if infection suspected, they go to surgery. It's recommended to get 3 to 6 cultures. Now I will say our spin on this, and it's a general consensus, if you did an aspiration and if it was a shoulder and it was a painful shoulder with a high sed rate, our routine in this hospital, we carry them all out for 14 days or 21 days now? 14 days, right. Because there's been a high incidence of P. acne infection, which takes a while to grow, and we like to carry them on. We don't carry all cultures out 14 days. Routinely here 5 days and stop. Some institutions will ultrasonicate the material around the prosthesis. There's supposedly a higher yield of organisms that way. There's work being done on PCR testing, but we don't have it available for us at this point in time. Okay, just a few pearls here. Post-op fever, we get called to see this a lot. Can last up to a week or more just from surgery. So again, examine the patient. If you can't find anything, you don't necessarily have to do something. You can watch and wait if you can't find a source of infection. Check the crit for a drop. It was 44 pre-op, it's 24 post-op. They have a fever and they look well. It's likely due to a hematoma. And examine the wound. Examine the wound. I can't tell you how many times we make rounds. I'll say to the nurse, how's the wound look? Well, I don't know, we haven't looked at it since surgery. So we got to look at the wound. The white count is usually normal in these folks, but it may be elevated simply from the bleed. So this is not an atypical case. Post-op, let me give it a little closer. So you see how far the hematoma? It goes all the way up to his hip. Trust me, it goes all the way down to his foot. So when you see this patient and there's erythema there and there's all this and his crit dropped 24 points and he's spiking to 101 and his white count's 13,000, what do? Well, my hunch is it's all hematoma. And I say, but, 5% could be cellulitis. So we treat these people empirically. Okay? But you can never be absolutely certain. You don't want to stick a needle in it for a risk of introducing something into the hematoma. So you treat, you watch, you wait. Now, if there's not any erythema at all and everything's flat, you can simply watch and wait. And it's not uncommon, about 4th or 5th day, we get called in consultation and we go through this and we say, do nothing. And then the next day, the temperature goes away. Okay. But low threshold for treatment on these patients. Obviously, all these other things are important as well. Check. I have not seen cellulitis from an IM injection in a long time here. We used to see them. I don't see them anymore. I don't know what they're doing right, but they're doing things well. Drug fever is something else to keep in mind, especially with vancomycin and some of the other drugs we use. Usually we see it on the outpatient basis after they've been on for 3, 4, 5 weeks or longer, and they also drop their white count. So that's something to keep in mind. Post-op leukocytosis, check the pre-op CBC. Can't tell you how many times they're your problem, not our problem. And did they have the first 3 questions? What was their pre-op wipeout? Did they have a splenectomy, or are they on steroids? And you will be amazed how many times that happens. So just ask the questions, think about it, and look for a bleed and a hematoma.
The leukocytosis is a stress response too.
Yeah,
so
sure.
It's not,
Yeah.
I think most of the time the normal pre-op
Yeah.
we see post-op.
But we had a patient, Roberta and I were talking about. We got consulted, and the first white count was 16,000. And they were all that high. And the last one was 6 years ago, which was normal. Well, what I didn't realize until he told me was he had an outpatient white count from somewhere else that was 11,000. So, you know, it was real, but you didn't know. And again, the usual. Just a word, prostate in men is a real, can be an enigma. So post-op fever, somebody who's been catheterized, think about the prostate. Just think about it. Because they may not have any other symptoms except fever. This is a patient that has required the effort of everybody in the institution. This patient has bilateral hips, bilateral knees, presented with a staph infection of the hip. It's a hip that's got the interosseous ingrowth of the entire prosthesis, rather just the top. So it's difficult to take out. Patient went for an IND and a liner exchange. The left hip, both knees are asymptomatic. Patient went for this 11 days ago. Pus, hence the incision extended all the way down to track the pus and drain it. Patient remained febrile with a white count, intubated to the present time. Okay? The wound, as you can see, doesn't look bad. Doesn't look bad. The knees, the other knees and the hip are doing okay. Workup, extensive workup, unrevealing for any other source of infection. White count, aspirated the hip, and aspirated the what on ultrasound was a collection here, still growing MSSA. So a failed effort at IND and liner exchange, a persistent leukocytosis and infection, any positive culture despite double drug therapy for 11 days. You can't treat this and cure this without taking out the prosthesis. And our concern is that he'll end up seeding the other hip and the other knees.
Now, we had a patient previously that we left things in because he didn't want to change it. He's on lifelong antibiotics. How often do you do that?
Frequently. So just in summary, history and physical is important. Check out what the pre-existing abnormalities and comorbidities are. It's elective surgery. Check the meds. And I think we can always remind ourselves of this every time we give a lecture or talk. First of all, do the patient no harm. I have one more slide to show you. Oh, 2 more, okay. One of the impetuses of this section, this whole series, was that we put together a monograph. Unfortunately, in my research, I found out HSS has beat it to us. They just came out this year. This is an entire book on perioperative care of the orthopedic patient. So for those of you who need another resource, I give you a referral with an incredible bibliography that goes with it. This is a tribute to my father, whose name is Galen. Galen was a Greek physician around 100 AD. And Galen is 90. He lives in a retirement community where he goes to shop and works every day. And when he was young, they called him Doc because his name was Galen. He's the first guy in his family that went to high school. I was the first one to go to college. So in tribute to my dad, there he is. Okay? Thank you.